Good afternoon, everybody, and a huge welcome from the University of Strathclyde to today's webinar. And today's webinar is being led by the University of Pavia. And I'll speak a little bit more about Pavia, and we will have a welcome from the university, from the pro-rector. But this is webinar 7 out of 9 that we're running. And it's very good morning to everybody in the US and Canada, to those of us in the UK and Europe and the Middle East, good afternoon. And for those of you from the Far East and Asia Pacific, a very good evening. Today's webinar is one that I must confess I have been looking forward to immensely. We have watched as our clinicians have stepped out of the shadow and into the limelight over the last 3 months in tackling the COVID outbreak and in getting us to where we are. So we're absolutely delighted today to have 3 of the clinicians who have been leading the way in tackling the COVID outbreak from the University of Pavia. And Pavia is based in Lombardy, as many of you will know. And Lombardy was at the heart of the crisis in Italy. So they have absolutely been leading in the fight against COVID. We have 3 presentations from Professor Fausto Baldanti, from Professor Raffaella Bruno, and from Professor Silvia Priori. The order that we're doing them in today is Professor Fausto will be the first one, and then Raphael, then Sylvia will be the running order. There will be plenty of time for questions and answers, so as ever, please use the Q&A function for your questions, and the chat function you can use just to say hello to everybody. But before I pass over to Antonella to welcome on behalf of Pavia. Pavia is one of the world's oldest universities. Pavia was founded in 1361, but there's actually been a higher education institution in the area since the 800s. So it is one of the universities in the world with the longest tradition. It has educated popes, explorers, has educated politicians. There's actually a connection to Scotland. It educated one of Scotland's leading clinicians, Hugh Crichton-Miller, back in the early part of the 20th century. So there's always been a connection. So we're absolutely delighted today to have Antonella welcoming everybody on behalf of the University of Pavia. So if I can hand over to you, Antonella, to do the welcome.
Okay, can you hear me perfectly? Okay, so good afternoon, good morning, good evening, depending on where you are. You are all over the world, so it is really a great pleasure to be part of this community. And I really thanks, first of all, Professor Goody, because he invited us and our university to participate to this webinar series on thriving after a massive global disruption. And my sincere thanks to Phil, because he really ran this webinar in a marvelous way. And we had a very exciting discussion in the previous webinar, and I'm sure we will have a nice one today. So many students and many educators in Pavia were quite excited about our participation to the webinar. And indeed, we had a lot of requests for attending the webinar. All of us indeed would love to move forward and leave behind this sad situation. And truly, this webinar series on thriving after massive global disruption, it really seems to help us to go in that direction. So as you well know, and Phil just said, Italy was among the European states the one that was most seriously hit by COVID-19 pandemic from the very early on period. And our region, Lombardy, it is actually one of the most infected region. And unfortunately, we also have the highest number of deaths. And even now, Lombardy in Italy has a high number of COVID-19 patients. So starting from the first week of March, and at the same time when the first red area were established in Codogno, that it is close by to Pavia, the University of Pavia stopped the class in person. And we move to online teaching and we move to smart working for our staff. It was not easy, neither for a student and for professor, and but we managed that. And actually, we managed to guarantee for all the students to complete their own academic course. And we guarantee the merit exam and now the graduation ceremony. So it's not in person, it's quite different, but we survive. So the pandemic also, it very badly research. The most part of the laboratory actually were closed, with the exception of the one that were focused on COVID-19 research activity, as you will hear in a moment. And I started my duty as prorector for international affairs just on time, the past October. So I can assure you that it has been a quite challenging period in my life. We have to revise completely our teaching, learning, mobility, and we reevaluate the mobility in different way. We actually put more focus on virtual mobility, and this was something new. So overall, we also had some strong stimulus to change our way to think about internationalization and international collaboration. And here we are. I think that our presence at this webinar series is a great example of how we can actually move forward even in a quite a difficult situation. But I don't want to steal any other time from Professor Fausto Baldanti, Professor Raffaele Bruno, and Silvia Priori. They are three excellent researchers in our university, and they were and they are really in the front line in the COVID-19 research. So I hope you have a good time with their presentation, and I leave you the, well, I should say the video, right? Not the floor.
Thank you, Antonella, and thanks for that very warm welcome from Pavia. Yeah, once again, everybody, if you use the Q&A, what we'll do is we'll have the three presentations, and then we'll have time for questions after that. So I'm going to hand over to Fausto. Fausto is a medical doctor whose specialization is in infectious diseases, microbiology and virology. So as you can imagine, he has had a hectic few months, and we're looking forward to hearing Fausto, who's going to talk to us a little bit about kind of the neutralizing activity, the diagnosis, epidemiology, and treatment of COVID-19. So I'll hand over to you, Fausto, without further ado.
Thank you. Hi, everybody, and I'll try to share here the, okay, can you see the slide? Fine. So, okay, so COVID-19. Well, actually, I don't know if you knew about Wuhan before the epidemic. Actually is a city of more than 10 million inhabitants, and honestly, I didn't know. And we learned about this city at the end of December, when this new virus, this new situation came to the news. And as already has been sometimes told, a virus is a piece of bad news wrapped in proteins. And actually, that was exactly what it occurred. Okay, I'm trying to. Okay, so Actually, China released the first case in, you see, 31 December 19. So COVID-19 just for a couple of days, 31 of December. A few cases in that city with a strange new lung disease that was rapidly growing and alarming the situation, and the city and the government of China, and finally releasing the alert on also in international authorities. This is the actually the email I received from the ECDC on January 10th, telling us that was actually a potential threat, and some information could be found released by ECDC and on how to diagnose and handle this virus. Well, a couple of days earlier, 9-10 of January, the researcher of China universities were identifying this agent, the agent responsible for this disease as a coronavirus. Well, actually, there were two major suspected. One was influenza, of course, and the second one was a corona because of the previous SARS and MERS epidemics, both of them starting from China. Actually, a corona in this situation, the one. And this is the new coronavirus. At this time, he had no name still. And one first new corona, and it was close as a phylogenetic standpoint to bat coronaviruses. And actually, these are the coronavirus, the 4 human coronavirus. There are 2 that are alpha coronavirus and 2 beta coronavirus. The 4 human coronavirus are responsible for the common cold every year affecting humans in the winter-spring season. And you see that corona as a whole are distributed among many different animals like humans, pigs, and also bats, but also camels, alpaca, and other animals, rodents, and so on. In particular, the beta coronavirus lineage had 2 additional new viruses, non-human at the beginning, SARS and MERS, both coming from the bat coronavirus, modifying them in mammalians, and then finally reaching humans. At that time, the problem where the virus was originating was pointed to the wet markets in China, and in particular on the use of bats for alimentary purposes in that country. Well, at the very end, what is important now is the impact of this new coronavirus on humans. Okay, so the 4 coronavirus are here, the 4 human coronavirus are here. These are the 2 alpha, in blue the 2 beta coronavirus, all of them quite similar in their genomic appearance. And here you have the SARS and MERS, okay? And so the receptors were already being identified because of the similarities with previous corona. Okay, having that sequence, so many labs in Europe and all over the world could develop molecular assays like the one we did. So we were, of course, using, having in the lab the ECDC suggested testing, but also we developed our own specific real-time PCR for detection and sequencing of eventual cases. So now we are in February 9. In February 9, the majority of cases are in China still. Some few cases, you see numbers, 161 in China, February 2, 40, whatever, 15 in other region in Asia, a few cases outside Asia in France, Germany, all import cases, and also in Italy, 3 cases. These 3 cases were through 2 Chinese visitors that became positive, so became symptomatic in Rome, and they were identified as COVID positive in Rome. One additional was a student from Italy that was in a sabbatical in China, has been taken back to Italy and was positive. So that were the single 3 cases present in Italy in February 9. And everybody was looking outside the border, the Italian borders. These are the case definition for surveillance by ECDC, suspected cases, requiring having clinical presentation, having had in contact with probable or confirmed cases of COVID. And all these cases were reported as outside, basically, Europe, China, Southeast Asia, or having had travel history with contact in that region. Actually, that was the approach. Everybody was looking east and outside, and we already tested 70 or 75, I don't remember, samples from travelers, all of them negative for COVID-19. Actually, now, this is the figures of these figures changed the world, at least in Italy. February 20, 2020, at 8 p.m. o'clock, we received a sample from a small hospital nearby in a city, Pavia, and with a young man with no travel history, having a strange pneumonia, and our region was regional authorities were asking us and another hospital in Milan to check for the presence of this new corona, even though the patient had no travel history. And that was the first case in Codogno, the case number 1. Immediately after, the contact tracing was trying to detect the limit, to limit the border of this outbreak. And you see, 20, 21, 24, 26, the very first week, testing revealed a high number of cases, more than reported in other countries, more or less, a week before. And so that was the first scenario we could imagine. A large outbreak in a patient, starting from a patient with no travel history. So we didn't know where the virus came from. And the first hit, all samples were tested. So symptomatic and asymptomatic patient. And the detection rate was 15% in the first week. So given the high number of samples that were releasing in the lab, there were only 3 labs in Lombardy, is a 10 million inhabitant region, Lombardy, that could run the COVID-19 test at that time. And so the regional authority started concentrating on symptomatic patients, and the detection rate raised to 33%. Okay. Still, sorry. A large number of patients symptomatic was negative for COVID-19. And that makes sense because flu was still around and the flu season was still ongoing. So there was a mixing of two respiratory viruses at the very beginning of the epidemics. Okay. However, the debate on whether or not the asymptomatic cases could transfer the virus, transmit the virus, was tested in the beginning. So these are all positive, COVID positive sample, are about 400 of them, you see. 77 were symptomatic, 5% were clearly without any reported symptoms. In this percentage, the report were unclear, so were not considered. What it was striking is that the viral load in the secretion was exactly the same between positive symptomatic and positive asymptomatic patients. So the capability of this minority patient to transmit the virus was the same of patient with the full-blown infection. Another important characteristic was that it was clear immediately the young people and children in particular were basically not affected by the virus, at least not as acute manifestation. But the infection, disease, and severe cases were restricted to the older age. Let's say from 60 to older strata of the population. So this is a sort of representation of the numbers we were running in the very first three months of samples. You see the blue are the negative, the red are the positive, and you can clearly detect the peak of infection and the trailing off of the infection today. So the peak of the infection was in the first 2 weeks of March. Okay, so what about the extension of this infection? So we developed an assay to detect neutralizing antibodies. Any infectious diseases, any viral infectious diseases develop antibody, and antibody can be directed against many structures of the virus. Few of them are hitting crucial structure, like in this case the spike protein, that is crucial for the virus to enter the cell and starting the infection. So these antibodies are called neutralizing. So we use that assay to track the extension of the epidemics in the initial red zone. So the red zone was a 169 square kilometer, including 10 towns surrounding Cudogno. It was the first lockdown area in Italy. Lockdown started a couple of days after detection of the first case. And in this area, there are many blood donors. And the blood donors are, donation can be done starting from 18-year-old to 70. So checking the prevalence of antibody in blood donors, you have an idea on the circulation of the virus in that population strata. This is the neutralizing. These are the actual number that we detected that are summarized here. These are the 10 municipalities, and this area includes 51,000 inhabitants, and the seroprevalence was about 23%. A few cases positive for the virus in the nasal swab, you could reach the 27% positivity. So basically, 1/4 of the population in the Lodi red zone had evidence of infection, while 3/4 were still susceptible to the infection. And this is a major point in order to implement all the potential contrast activities. You can also estimate how many individuals have been involved in the infection, about 10,000. Okay, adding neutralizing activity titers, you can also estimate the amount of them. So how many asymptomatic or pouchy symptomatic or mild infection that are typical, that were typical in blood in the red zone, you develop. So a tiny percentage has high titer, while the majority low neutralizing titer. It is quite different from patients from the infectious diseases department, Professor Bruno, that were overcoming the infection. So the extension, the clinical impact is also a key factor for developing high titer of neutralizing antibody, or even medium titer. And so now we have a clear idea on where to go for identifying potential donors, plasma donors for treatment. Having this sera characterized, we could also develop, we could also collaborate with the companies to develop automated assays for detection of antibodies and for the semi-quantification, automated semi-quantification of the neutralizing activity in order to expand the access of potential blood donors to implement hyperimmune plasma treatment. Meanwhile, also the concept of asymptomatic was modified. So, well, we now know that COVID-19 is related to many more clinical presentations that first observed. So not only respiratory diseases, but also olfactory and taste disorders are typical of this disease. These are two scales determining the level of these luckily temporary disorders, time zero, the infection, 7 days, 14 days, and so on. And this clinical presentation is also paralleling the decline of patients positive for the virus in their nasal swab. It is a gray bar. Why? It is inversely correlated to the starting and detection of patients with neutralizing antibodies. At the very end, at the very first part of the infection, you have the virus and antibodies. At the very end, you have no virus and neutralizing antibody. And as the titer increase, also the viral load decrease. Okay, so these antibodies can be used potentially for treatment. That was a question that Raffaele and I were actually sharing one Saturday. Maybe it was the first of the second week of the infection, the first of the second weekend that we were ending up being in the lab, in the hospital. And actually, we started this protocol with a colleague from the transfusion department and colleagues from the Mantova hospital to test the hypothesis of reduction of mortality. The expected mortality at that time was estimated about 15%. So 1 patient out of 6 ended up with unfavorable outcome. That was on a national basis. On a local basis, the mortality rate was even higher, was approaching the 30%. Expecting a reduction of mortality, and indeed the mortality was reduced to 6%, meaning 1 patient out of 16 patients. To reach that goal, 46 patients were enrolled. These are the clinical characteristics, all of them with severe lung impairment, severe respiratory distress, and all requiring mechanical ventilation or assisted ventilation, and all of them receiving high titer hyperimmune plasma, matched for the blood group, of course. These are the results. Beside the reduction in mortality, there was a clear increase in the oxygenation parameters in the radiograms, and also in decrease in the inflammatory parameters. Of course, this was a study designed for short-term effect, so mortality within 7 days. This is a way to show the increase in ventilation. These are the 43 alive patients and the 3 that we observed, and the reduction of the inflammatory parameters measured in the survivors versus non-survivors. Okay, finally, one more epidemiological information. So in Lombardy, there were 2 large major outbreaks. One in Lombardy, that is here, southeast from Milan, and one in Bergamo, that is northeast Milan. And all the containment barrier was in this direction in order to preserve Milan from the infection. In Milan, there were cases, but basically the metropolitan area has been really protected by the battle that has been fight in this here between Bergamo, Lodi, Pavia. Pavia is here. Okay, so what became now evident from the analysis of 346 SARS-CoV-2 sequences recovered from patients from the beginning of the infection to the 20th of April all over the Lombardy, is that there are clearly 2 clusters, 2 different clusters of the infection, cluster 1 and cluster 2. While cluster 2 is more genetically homogeneous, cluster 1 is divided into 2 small, lineage 1 is divided into 2 small clusters, plus other dispersed sequences. So 3 different genetic profile for lineage 1 and 1 single lineage profile for lineage 2. All these genetic profile were present in Lombardy starting from January 1815, so the middle of January. So this is a document, the first document of the appearance in Italy of this new virus. So well before, at least 1 month before the detection of the initial case, and the inapparent circulation of this respiratory virus among all the other respiratory virus in an ongoing flu season, well, that was most likely one crucial point for the spreading, for the high spreading of this virus in our region. Okay, so I think that was my, oh, okay. Very last slide is this one. Lineage 1 was predominant in the outbreak south east, while lineage 2, the more homogeneous one, was more predominant in the second outbreak that was in northeast Milan. So at the very end, we had the virus on our territory well in advance to the first detected cases and in that specific situation, and that could have impacted the first detection. So that was my last slide. This is a small portion of working full-time, 7 days a week, 24-hour day on this emergency. And I thank you for your attention.
Thank you, Fausto. That was a hugely insightful presentation. And what we're going to do is we'll gather up kind of all the questions that are coming through directly and through some of the other channels, and then we'll maybe kind of have a group discussion at the end of it. So what I'd like to do then is to move on without further ado to Professor Raphael Bruno. And Raphael is Professor of Infectious Diseases at the University of Pavia and at the teaching hospital. And Raphael is going to speak to us today about the clinical features of patients infected with the 2019 novel coronavirus. So if I can pass over to you, Raphael.
Thank you. Thank you. Did you listen to me? Hello?
Yes.
Yes, it's okay. Just a second. Okay, just a second. Okay. First of all, thank to the organizer for inviting me. In the next 10 minutes, I will show you the San Matteo Hospital experience about the clinical features of patients infected with the novel viruses. Let me start with this slide. One of the main problems was the reorganizing the wards. As you can see in the slide, we convert a classic infectious disease ward into COVID response center. In fact, in the red part, we arrange a sub-intensive therapy ward. And on the ground floor of our clinic, we arrange an emergency room only for COVID patients. So we also tried to understand if there was a survival of the virus on the surface. And in this slide, you can see the map of the world where swabs for SARS-CoV-2 RNA were obtained. And red dots indicate the site where swabs were applied. We did not able to find the SARS-CoV-2 RNA. This was important information because in the middle of pandemic, we don't have enough protection for manage this infection. This was the first paper that we published, and because since no one had experience on COVID-19, and the only information was that of international literature from China. Therefore, we also wanted to describe our experience in the first week. And as you can see in the slides, the multivariate analysis showed that they age less than 65 and antiviral therapy. And at that time, antiviral therapy was the antiretroviral therapies, in particular lopinavir, ritonavir, was correlated with lower probability of discharge. And another important thing was that we discovered that the level of LDH is correlated with severe disease. As you know, the most important target of this disease is the lung. And also we studied the lung disease, and the aim of this study was to analyze the most frequent radiographic features of COVID-19 pneumonia, and we assessed the effectiveness of chest X-ray in detecting pulmonary alteration. The most important lesion in COVID-19 patients were the ground glass opacity, and this was very typical in the intermediate late phase, and reticular alteration in the early phase. This was very important because, for example, in China, they perform a log TC scan instead of traditional radiographic techniques or ultrasound lung scan. Increasing the clinical evidence showed that the most common comorbidity observed in COVID-19 patients that are associated with worse prognosis and high rate of death. For example, was systemic hypertension, diabetes, and obesity. This is strictly correlated with the endothelial dysfunction. Our data that I show in this slide confirm the stand previous observation, supporting and underline that SARS-CoV-2 is related to endothelial dysfunction, and this increased the risk of venous thromboembolic disease and also systemic vasculitis, endothelial cell apoptosis, and inflammation in different organs. For this reason, we also evaluate the presence of the venous thromboembolism in our patients. And here you can see a single center experience that we found the very high prevalence of patients with thromboembolism. Also, we suggest to perform venous ultrasound in patients with the Padua score more than 4. And this is very important in management of these patients. Just a few slides, but Silvia, we talk about this is the clinical manifestation in the clinical manifestation observing during COVID. This also was myocarditis. Just to show you very briefly, in this picture, we are able to find the SARS-CoV-2 in myocardium, and also in this slide you can see the clinical picture of acute myocarditis in very young patients. In particular, it's very important to see the box E that RM showed the sequel, in particular the necrosis induced by myocarditis. Another important clinical picture in this disease is the cutaneous eruption, and especially in the late onset of the disease. And here you can see the rash is very common in the late phase, as well as some acral lesion and also livedo reticularis. Normally, in this clinical picture is very common in the late phase of the diseases. It is strictly correlated with the clearance of the viruses. The role of immunosuppression in SARS-CoV-2 related diseases is matter of debate. In our experience, the clinical course of COVID-19 in patients on immunodepressed patients is generally mild. We observed that not only in transplant patients, kidney transplant, lung transplant, heart transplant, but also in HIV patients. We try to cover all aspects of the SARS-CoV-2, and also covered the pediatric and adolescent aspect. We performed this systematic review, and as you can see, a lot of the clinical manifestation in this setting is mild, and this was confirmed also in our series. Also, we covered the nutritional supplementation because COVID-19, as you can see, one of the most common symptoms in advanced patients with COVID-19 is the involvement of the gut, because in the gut there are a lot of ACE receptor. For this reason, they develop diarrhea and gastrointestinal symptoms. The frequency of smell and taste disorder are common in COVID patients. In this figure on your right, you can see the presence of SARS-CoV-2 in the olfactory bulb. This is demonstration of SARS-CoV-2 is a virus with neotropism. For this reason, the disorders of smell and taste was very characteristic of this disease. Let me finish the presentation with the 3 slides, because we at San Matteo Hospital, we took a part in a study with remdesivir. Here you can see the article published in New England Journal. This was the compassionate use of remdesivir. This was very important study because we demonstrated the clinical improvement in 68% of patients, and this was very important because after this paper start the fast track for clinical trial the clinical trial. And here you can see the trial that shows that the 5 days of remdesivir is equal to 10 days. This was very important because this drug work well, but there are some problem with hepatotoxicity. For this reason, 5 days is very important to short the treatment in this setting of patients. We also study another kind of drug. We do not study only antiviral, but also we try to use tocilizumab. Tocilizumab is a drug that already used in rheumatoid arthritis, is an antagonist of IL-6. At the time, we tried to evaluate the aim of the study was the evaluation of ICU admission at 7 days or the mortality rate at 7 days. Unfortunately, our study did not show the admission of tocilizumab, did not reduce the admission or mortality rate in court in this court. This result was confirmed also in very big trial published 2 days ago in JAMA. So let me finish the last but not the least, our paper published in Nature Medicine. In this paper we try to modeling the epidemic. Our finding provided the policymaker with a tool to assess the consequences of a possible strategy, including the lockdown. I would like to underline that the lockdown was very important. I mean, in Italy, because right now the incidence of new infection decrease, and probably this is the tail of the very important lockdown. Thank you for your attention. I finished my presentation.
Many thanks for that, Raffaella. Again, another kind of massively insightful presentation. Again, we've got questions that are coming through, but if everybody's comfortable, I'll leave it until the end to put the questions, because I think that all of the panel will have something to contribute to the questions. The final presentation today is coming from Professor Silvia Priori, and this is again, it's going to be a fascinating presentation. It's looking at the heart. Silvia is a cardiology professor and is looking at the heart, an unexpected player in COVID-19, and there's almost two parts to this. There's the impact that it's had, but also the fact that people have not been attending hospitals when perhaps they should have been. And I think we sometimes forget that although COVID had a very direct impact on the health and well-being of the world's population, and in particular in Italy, in the UK, Spain and France. But there's also that indirect impact that it has, where other conditions that would otherwise have been picked up on are somehow kind of put down the order of priority. So Sylvia, can I hand over to you and look forward to your presentation, and then we'll deal with some of the questions.
Thank you very much. Are you seeing my screen? Okay. Thank you very much for the previous presentation that provided an excellent background, and some of the aspects of the role of COVID infection in the heart has already been touched. I'm the professor of cardiology at the University of Pavia, and I would like to describe to you the evolution of our understanding of how the heart is unfortunately one of the target organ of the COVID-19 disease. So as we have heard by the previous speakers, COVID-19 is so aggressive and malignant because it causes a multi-organ damage. And among many organs that have been described as being infected by the virus that has receptors probably in most of them, the heart is still one in which we have different opinion and different concerns on how and what mediates the derangement of the cardiac physiology during this disease. So let's start from the early observation. It was very early in the epidemic that scientists from Wuhan who were exposed to the first cases sent a clear signal to the world by saying that 30% of COVID-19 patients presented signs of myocardial injury that was predominantly called myocarditis, and we'll go back to this issue. So I'm focusing on this because this message was very clear, the data were obviously strong, but the message was a bit not well perceived, and the focus remained, of course, on the lungs that were manifesting so much the symptoms of the patients. But if we look at these slides that show the relationship between mortality and cardiovascular disease, we can see that the very high mortality is present in this line that represents the mortality of patients with cardiovascular disease infected by COVID, of course, and elevated troponin T. Troponin T is a biomarker that indicates the active phase of a cardiac injury. So even in the patients without cardiovascular diseases in their history, so without the risk factor represented by having cardiac diseases, the fact of manifesting signs of injury to the heart by this same biomarker, the elevating troponin T, was associated with a high mortality. And now here we see the blue line that is the line for the patients who have the risk factor. So they have cardiovascular disease, but they don't have an active phase of the cardiac involvement. And the mortality in them is so low that it really overlaps in patients even without cardiovascular diseases and normal troponin T. So having heart diseases is a risk factor, and having them in an active phase when you have the infection and the cells are actually dying in the heart is really a predictor of adverse outcome and a clinical problem that is quite major. So two aspects are clear. The cardiovascular comorbidities, even in the patients, seem to be controlled. Let's take hypertension. The patient had hypertension for many years, was treated, but still that represented an indicator of more complications in the outcome of the patients. And then I want to focus on the story of the coronary artery disease in COVID-19. Thrombi in the coronary arteries that may lead to myocardial infarction or may lead to a chronic disease that gives patients pain and chest symptoms but doesn't evolve in cardiac necrosis are very, very prevalent in the general population. So what we have seen, is that during COVID-19, the patients who had these chronic coronary artery diseases were much more prone of developing an acute myocardial infarction or an acute coronary syndromes. So the fact that we were seeing, the fact that the COVID could precipitate these acute myocardial infarctions in patients who had these limited coronary artery flow, but in a stable and mainly asymptomatic situation, raised different hypotheses. The first one is that the increase in myocardial oxygen consumption triggered by the viral infection, the tachycardia related to fever, could be something put in these patients under stress and therefore having the myocardium that could develop a myocardial infarction. As a second aspect of the acute infection with the coronavirus was that it has been discussed in many topics of the pathology that circulating cytokines were really important in mediating organ manifestation at different levels. And also in the heart, the severe inflammatory stress had been associated to something that could precipitate a very specific pathophysiological event, that is the destabilization of the aortic plaque, leading to the rupture of this plaque. Then that is what triggers the acute coronary syndromes. So the infection itself had different means, direct and indirect, of destabilizing a coronary artery disease that in patients might have been asymptomatic for many years. Then, on the aspects of acute coronary syndrome, there were other layers of complications or consequences of the viral infection that would predict a higher incidence, a higher occurrence of acute coronary syndromes in these patients. First of all, the infection is associated with dysfunction of the renin-angiotensin system. The very same receptor to which the virus binds has a cardiovascular flavor because it's a receptor that is very important in determining the physiology of this axis that controls many different functions in the heart and vessels. And the alterations that can be present may promote platelet adhesion and aggregation. And of course, this is one of the steps of thrombosis in the coronary arteries. And then again, the cytokines, what they can do, activate the coagulation cascade. So it's a perfect storm that could activate anything you can have in the body to predispose to acute coronary syndromes. But what we actually observed is what we called the paradox of acute coronary syndromes that all the cardiologists were noticing in their words around the world. Rather than having all these aspects leading to an observation of a much higher number of patients with acute coronary syndromes during the COVID time, what was actually observed, the paradox, is that as compared, for example, to the epidemiology and the prevalence and incidence of the disease between 2017 and 19 in the same month in which we had the pandemic of the COVID-19, in blue you see the data from previous years, and we see a decrease in the acute coronary syndromes during the COVID time. And then we see that we move out of the acute phase and we stabilize a little bit more our understanding of the disease and the numbers start going down. The number of acute coronary syndrome have increased. So what is the reason for this paradox? Well, it took some evaluation, assessment, and convergence of data from different countries and different hospitals. And the reality was that actually patients were staying home while they were having coronary artery disease becoming acute and leading to myocardial infarction. And the patients were not going to the emergency room for the concern of getting COVID-19. So actually, what has happened is that we have seen a return to the manifestation of an acute myocardial infarction that we were seeing something like 20 years ago. Right now, a patient goes to the emergency room and there is very rapid revascularization. The vessels are open and that preserves the myocardium. All these patients that were not going to the emergency room are now coming to our attention progressively with signs and symptoms of myocardial infarction that, not being treated, has created major damage to the heart. So it's very sad, and it's telling us how the virus not only has attacked and created the damage because of the infection, but the psychological concern that people have had of this virus specifically has prevented them from seeking medical attention with very severe consequences. I had mentioned before myocarditis, and this is the same study from our university that Raffaele mentioned before. So myocarditis is a common abnormality and disease of the heart that is usually associated with a viral infection. So what the viral do, they enter into the cardiac cells through receptors, and then progressively they lead those cells to death, and the death becomes a scar. The scar can be so massive that the patients can actually have acute heart failure and even die because of an acute fulminant myocarditis. So when we started seeing that patients had evidence of scars and fibrosis in the heart, even at very young age, the concept of having a myocarditis, so also when the patients had unexpectedly a decrease in the contractility. Analyses were done to try to see whether in the cells, or in the tissue of the heart, mRNA was there. And indeed, it was found there. So the straightforward hypothesis was the virus is in the cardiac cells, as every other virus, and is leading to myocarditis. But actually, this study very clearly demonstrated from the endomyocardial biopsy of a 69-year-old man with normal coronary arteries, so non-ischemic patients, and an acute decompensation, all the manifestation that would lead to the diagnosis of this rapidly progressing myocarditis. But then the electron microscopy revealed that yes, in the cardiac tissue, the virus is there, but is not in the myocytes. So it remained in the interstitial space. And so the question whether actually we are seeing such a massive heart damage, and it's not because the virus is killing the cardiac cells, because this paper could not show that actually the virus was in the myocytes, led to the hypothesis that acute myocardial damage and necrosis may be secondary to systemic disease. So once more, there are two ways of damaging an organ. One is a direct, the virus, one is secondary, and possibly in the heart, there is still debate, but it's possibly there is a secondary damage that leads to heart dysfunction. Another phenotype that manifested during the COVID epidemic in a very strong way was the predisposition to arrhythmias. And in particular, the study from our university showed that ventricular arrhythmias and sudden cardiac death, the most malignant form of cardiac arrhythmias. So this study was started with the observation from a survey of the Heart Rhythm Society that sent the message that actually sudden cardiac death was something more prevalent during the COVID time. And here you see from their data that while atrial fibrillation, a common, maybe much more benign arrhythmia, was frequent, if you look at these slices all together, they lead to sudden cardiac death. So this is the portion of patients having cardiac arrest, the portion of patients having ventricular fibrillation and ventricular tachycardia degenerating into VF, and patients having very severe cardiac arrhythmia, sustained monomorphic ventricular tachycardia and polymorphic ventricular tachycardia and torsade de pointe. So this is the fraction of patients at high risk of sudden cardiac death that we have observed more than before. So when a comparative study was organized by the cardiology at the San Matteo Hospital, what it was shown is that taking 4 provinces of the hot zone that you have seen in the presentation of Professor Baldanti at the beginning, what they were able to demonstrate looking at the occurrence of out-of-hospital cardiac arrest is clear here in Lodi and in Crema, 2 cities very heavily hit by the virus. These are the number of cases in the same period other years, and in blue you see what happened this year. So this also is clearly evident, how strong the increase in out-of-hospital cardiac arrest. And this could also be related to what I said before, patients hesitating in going to the hospital until the manifestation of the cardiac involvement became very severe. So just to conclude about the pediatric population, we have heard at the beginning of the COVID that children were spared. But over time, actually, what the pediatric community has been able to show is that actually the children have different manifestations. And talking about the heart, I think that what was seen in the pediatric wards was an increase, an unexpected number of young children with left ventricular dysfunction, raising the issue that this could be a myocarditis type of involvement or it could be something else. And this study from Bergamo Hospital showed that, again, in our region, what happened has been a 30-fold increase in the Kawasaki disease that they call Kawasaki-like, because there were profiles of the disease that were different from the typical Kawasaki. So the patients were older, usually is a disease that starts in children very young, 2-3 years, and here was more 5 or 6. Higher rate of cardiac involvement, and in particular of the coronary arteries that get dilated. And that, of course, can lead to tragic events like the rupture of the coronary artery and heavy macrophage activation. So in conclusion, the involvement of the heart is indeed very important in COVID-19. It starts from the patient that simply have cardiac comorbidities, and they should be immediately identified as patients to be protected for getting exposed to affected individuals with COVID-19 because their risk is higher. Then there are several acute and very severe occurrences, cardiac diseases that may manifest for the first time in affected patients. And in particular, I pointed out the role of the acute coronary syndromes. However, whether COVID-19 is characterized by the penetration of the virus in the heart remains unknown. And all these diseases like acute heart failure, myocarditis-like manifestation of the infection, and then dysfunction of the heart, or acute coronary syndrome that is leading to myocardial infarction and to dysfunction of the ventricles that possibly leads to cardiogenic shock, may be secondary manifestation of severe COVID disease, even in the absence of the viral localization to the heart. Thank you very much for your attention.
Thank you, Sylvia. Thanks for another fascinating presentation. We've got time just for a couple of questions that have come through. What I've tried to do is to group them into kind of common themes that I can try and ask. So I've got maybe 3 themes. One is around vaccination, one's around screening, and one's around medication. So can I just start with the vaccination theme? We've never actually managed to develop or to launch a vaccine for a COVID, is my understanding. And just from the panel's perception, do you think we are likely to have a vaccine in the near future, or are we some way off of that? Can I start that with Fausto?
Well, thank you for the question. As far as I know, there are at least 17 different projects in advanced phase, let's say phase 1 at least. And so the concept for a vaccine are all there. There are many different approaches, from the spray to the intramuscular, so deliver a different delivery system, including many different proteins. Well, so I think vaccine could be ready soon. The problem is how big can be the capacity for industry to prepare billions of doses to be released.
Thanks, Fausto. And Raphael, do you have any kind of thoughts on timescales where we might be able to optimistically look for something that would be able to be scaled up? I know that the UK government have ordered many millions, I think, from GSK, who have suggested that they're going to be in a position to scale up very quickly. Do you have any thoughts on kind of timescales?
I agree with Fausto. The problem is right now is not only the discovery new vaccine, but only the production, because the production is very complicated right now. I don't know, Fausto, what do you think about the production of the vaccine after the discovery of the vaccine? Do you want to make a comment, Fausto, about the?
Yes, as I said, is the point. So how big is the capacity to produce that many doses and to deliver them in a right time? And we don't know actually now if one single shot is enough to submit to vaccine couple of times. So again, couple of times means doubling the doses, for instance.
Do you think, is it?
So the problem.
May I ask a question and a comment? Because do you think different vaccines with different approach arriving in phase 3 in the same time and then arriving in the market in the same time, some part of the world or the population will vaccinate with the kind of vaccine, another part with another kind of vaccine? You know? You understand what I mean?
Well,
if
yes.
We have different kind of vaccine.
Well, that's a problem because again, phase 1 is a short phase. You have a few volunteers. You vaccinate them, you wait the months, and you check the antibody production. Guess that you already have all the doses. Well, you have a couple of vaccines in a couple of different regions of the world that are competing for having the vaccine, if it works. So production and distribution will become.
Oh, I think we may have lost Fausto there.
Is dangerous. The vaccine is dangerous.
I can see he's coming back in. I think possibly he's just, let me see if I can unmute Fausto. Just while we're waiting on Fausto to come back on, if I could just maybe jump to another question then, maybe one for Sylvia to pick up on, which is if we do find a vaccine, we won't have, because it will have been produced in almost record-breaking time, we won't really have any understanding of the long-term effects of it, or whether or not it will be useful, or what its efficacy will be if the virus should mutate at all. Can we give this to patients without knowing what the long-term effects are likely to be?
I'm not an expert on the topic. I can say that by reading and thinking about these, I can see your point that there might be concern. On one side, we need this vaccine to be ready soon. On the other side, we also need them to be tested well. So my question that maybe I can pass to my colleagues, is whether seeing this small number of patients that actually after the infection have the antibodies, is this something that gives you concern that maybe the vaccine might not be so effective in protecting, or you think that would be a totally different response, the one to the vaccine?
Well, there is a good news. So the virus is stable, is genetically stable. So the scenario of a flu vaccine you have to modify over time and over a short period of time is unlikely. So at least a working vaccine can be predicted as working for everybody, because the virus is quite stable genetically.
Excellent, brilliant. Thanks for that, Fausto. Okay, if we could just move on a little bit to there's been a few questions around testing, and one of them I'll kind of try and roll them into one question, although that they are kind of a little bit varied. But one of the questions that came through is, do you think that PCR COVID testing of symptomatic at a population level has a role in the disease suppression? And for those non-clinical colleagues who are on today, PCR testing is where you're detecting antigens rather than the antibodies. So you're detecting the virus and the poisons that are in the body. He says in a very, very simplistic layman way. No doubt Fausto, Raphael and Sylvia will be horrified at, but that's for our non-clinical colleagues. But do you think that there's a role at a population level of doing this?
I don't
to detect and... Okay, Raffaele, go ahead.
So the question is if the PCR COVID testing of symptomatic at population levels has a role in the disease suppression. This is the question. I don't think so, but I am not expert in lab. I don't think so. Really, the situation is different. As Fausto said, the virus is stable. The quantity or the amount of antibody remain quite stable after 1 month. Correct, Fausto? And there is a decrease in some of them. This is my suggestion.
Okay, yeah, thanks for that. Fausto, do you have any thoughts on?
Well, to detect the contagious patients, you have to search for the RNA of the virus or the antigen of the virus. And that is of paramount importance in order to intercept the patients that are contagious and quarantine them. Antibodies can be used at the very end of the infection to define when the patient is recovered or for epidemiological purposes. On the other hand, implementing a population-based screening is really complex. Lombardy has 10 million inhabitants, and we have 3/4 of the population that are susceptible still after this big wave of infection. And so population-based, that means that we have to screen 7.5 million once a week. Okay, so
probably is very important in a very little outbreak. In very little outbreak, as in Veneto region, as Bolugano is probably the best strategy.
Brilliant, thanks. We've got time for 2 more questions. I'm just kind of conscious that we're eating into Fausto, Raphael and Sylvia's time. Sylvia, I think this one's one more for you, and it's asking if there's any research into the positive or negative impacts of ACE inhibitors, ACE inhibitors, in patients taking them, for example, for blood pressure. This is a heart medication that's used to dilate blood vessels for our non-clinical colleagues that are on. I'm just wondering if there's been any research into positive or negative impacts of it.
Yeah, this has been a very popular topics in the cardiology community because we were immediately bombarded by patients asking, should I stop my medication? Should I take it twice a day because it might be protective? So there was a major confusion, but thanks enough, the Hypertension Society, European Hypertension Society took the issues very seriously and made a study that pointed to the fact that was confirmed by many other studies that there is no action and no modulation on the severity of the disease on patients taking even different types of the ACE inhibitor. So all the patients have been reassured that they could continue their therapy, not getting benefit, but not getting harm.
We also evaluate this issue, and we do not find any kind of correlation with the severe disease. I mean, there is no difference in survival.
Right, excellent, right, brilliant, okay. So we've got one final question, and an interesting one that perhaps even controversial, which says, do you agree with your colleagues at the San Raffaele Hospital in Milan that the COVID is becoming less virulent, and what is the evidence? And it's an interesting one because this is a conversation that's come up in the UK recently. We had several demonstrations, particularly around the Black Lives Matter movement, where we had lots and lots of people together in a relatively small area, and there was a feeling that this could lead to a spike, which didn't really seem to have happened. And so maybe that's kind of feeding into some of these conversations as well, that the disease is becoming less virulent. But I think that, yeah, interesting question. Can we start that one off with you, Fausto? And hopefully you can give us an answer that will mean that your friends and colleagues at the San Raffaele Hospital in Milan will still speak to you after this.
I have the conflict of interest, you know. My name is Raffaele, I have conflict of interest.
I assumed that they'd named the hospital after you, after your work over this last 3 months.
Yeah, also because after the saint. Okay, anyhow, so the clinical manifestation we see is less important, but we see also a lot of many cases. So it's an iceberg. So the tip, if the tip of the iceberg is 20%, 20% of all the infected are severe. If you have 1 million infected, then 20% is 200,000. If you have 10 infected, there is no severe. So basically, it is also a matter of the amount of infection. And the clinical presentation, you remember, are the most severe, of course. And we all in Italy remember when there was a time that all the emergency room and all the intensive care were full stock of patient and patient waiting outside. So you see, well, this is a monster. Then reduction of this situation doesn't mean necessarily that the virus is less virulent. We have less virus around. From a genetic point, we don't see that many variation. So I cannot understand very well this point from a biological standpoint.
Great, thanks. So Raphael, is that, and Sylvia, would you kind of go along with Fausto's position on this, or do you have any differences?
No, I totally agree with Fausto.
Excellent. We've got, there are a few more questions, and we could carry this conversation on all afternoon, but as I say, I'm aware of the fact that we have now run over a little bit longer than we had promised. If you don't mind, what I'll maybe do is we'll make a note of 1 or 2 questions that haven't been answered. Some of them are a bit more technical, and we'll maybe drop them in an email through to you to have a look at and get your thoughts on. That brings us to an end today. I will, just before we go, I will pass over to Antonella to say goodbye on behalf of Pavia. Don't forget, students that are watching, for those of you that are doing the 70% or 75%, I need to double check my figures now for the certificate. Keep track of that, and we will as well. And for those of you that manage to do 100% of it, you will get the certificate with distinction. Next week, we are off to New York, where the City University of New York will be presenting, and that we will send out to you some more information on through this week. So we're very much looking forward to City University of New York next Tuesday. And all that remains is for me, Phil Considine, on behalf of the University of Strathclyde and Policy at Strathclyde, to say a huge thanks to everybody for joining us, and a massive thank you to the University of Pavia for what has been a quite remarkable webinar with some amazing insights. So Fausto, Raphael, Sylvia, thanks very much. And I'll hand over to Antonella now just to say goodbye from Pavia.
Okay, I hope you can hear me. Well, first of all, thanks to you. It was a really nice webinar, and I really thanks personally Fausto, Raffaele, and Silvia. I was sure that their presentation were outstanding, and indeed I think they were. So I hope that the high number of participants, was impressive. They stay until the end, enjoy as well the talks and the discussion that you handle in a superbous way. And well, thank you to Strathclyde. I think this is the beginning, I hope, for a long collaboration. And well, bye to everybody. Again, afternoon, evening, and morning.
Bye.
Next week, bye.
Bye-bye.